Look at this.
Well, wait a minute, they not,
It's
they
like the
only
Baptists,
film
we're all
the
on one
person
side.
speaking now, right?
I think so.
All right, come on, Dallas, I can go over there. We're here.
Let's go. Hello, hello.
Oh,
Go be go.
that is on.
I'm gonna pull a Ralph Emerson. Good morning.
No, right.
Morning.
They go back there.
Who's in charge here?
That's interesting. Nobody.
Motion and second. Verbal
Hello, hello. We're gonna start.
It's gonna show up anyway.
We're in at 3:30, so. Wait.
These have special people with names and all
You are
that.
one of the special people.
You are special.
You are one of these special people.
Thank you.
She's back.
How are you doing?
Do we have any citizens that have signed in to
I don't believe we do.
see Jan Michael or?
Good, I remember.
No, but we've got it checked. We do not.
The minutes are, we're not ready, so they're not in the packet. And then the next thing is approval of 2 hospital district policies. Who presents those, anybody?
The MM 700 is the policy where they're approving the policy that creates it assists JPS ensuring that we're in compliance with the 340B drug pricing program, and associated with that is MM 701, the procedure that sets forth all the statutory definitions and the particular guidelines and practices that are to be followed at JPS pursuant to federal regulations on the matter.
What are 340B drugs? Somebody,
Have the best answer for you.
Bill, can you?
340B.
What are 340B drugs?
That's the big stuff.
Just come on up.
I just,
340B is the federal program that enables safety net hospitals, and now it's kind of expanded beyond safety net to every hospital in the nation, but they work with the drug manufacturers to get significant discounts on medication for patients of safety net hospitals. So patients who see our physicians at this hospital enable us to provide reduced cost medications to them for the prescriptions that are written by the providers. It's about worth $50 million to us every year.
did we get 50
That
million?
we get, it's reducing our cost by approximately $50 million. It's a big, big deal. And the drug manufacturers are pushing back on that. They want HRSA, which is a federal agency, to revise that program because all that we have right now are guidelines. There are no regulations. And this has been in the mix for probably the last 6 years to revise those guidelines to make them very specific. And the drug manufacturers feel that perhaps they're giving away far too many reduced price drugs than they need to. That's just the reality of it. And the lobby of the pharmaceutical industry is hot and heavy behind this. No question about it. So there's several things that we have to do to comply with those guidelines. And we've had audits over the last 2 or 3 years, and we are in compliance with those current guidelines. But there's potential that those guidelines will be revised this year. We don't know what that looks like, what that means. It's under comment period right now.
Okay. So that'll be can we make that sort of a follow-up?
Sure.
Once the
Nope,
new
nope.
guidelines come out, just,
No problem. And there's a variety of new guideline rumors a lot. But when they come out, we will definitely give an update. 340B funding is critical for us, and it's critical for our patients. And it's been, since I came to JPS, constantly on the potential cutting block. And it probably was 10 to 15 years before that. It's constantly talked about. As Bill enumerated, it is an economic issue for certain pharmaceutical companies. They don't appreciate that. We obviously watch very closely with what we do and what we don't do. That is a process by which our patients get that benefit if they see our doctors. Our patients can't go anywhere else and get that benefit, but they can if they're here. And it is to people that have a real challenging time, and I think you have to put yourself in the perspective of a world that many of us don't live in, that are in this room right now, that a $10 copay can make a significant difference. These are people that need that desperately. So it is a really good situation for people who really need it. And we're very strict in making sure that we stay in that lane of the people who need it. But yes, I will do that. Both of these two policies, and Madura is here for the second policy, but both of these two are no substantive changes to the policies. And I know that legal counsel can speak to that, because our legal counsel is obviously the one that reviews those, and they're certainly going to be the one that's astute on that. So they'll be happy to talk more about it.
Robert, if I correct, just follow, you're saying it's attributable only to hospitals like ourselves?
Yes.
Safety net, that's what.
Yeah, but safety net becomes an expanded term. There are other hospitals that receive 340B funding for the people that come in the door. I don't want you to think that it's just public hospitals or just truly your definition in one's mind of a safety net hospital. I know that THR has the 340B funding program as well.
And from my perspective, that's where the pharmaceutical industry is
Right.
proliferating. That concerns me.
Comes down to dollars.
$8.
Okay, could somebody make a motion to?
I'd move for approval.
So Charlie Powell, Elvis, approval, DT, all in favor, please say aye. Aye. Those opposed, same sign. Thank you for the little summary, Bill.
RC 200?
Yes.
RC 200 is the record management policy, and associated with that is RC 201 Records Management Program Procedure, which has, it really is mainly about the record storage and records retention at JPS, that procedure. It's an extensive document. It follows specifically the state of Texas regulations related to records retention. The changes, any changes that were in here were just to keep up with the current regulations by the state, so non-substantive.
Anybody got any questions for Alan? If not, entertain a motion to approve. DT Wynn approved. Dorothy,
Second.
any discussion? All in favor, please say aye. Aye. Those opposed, same sign. Brian, is this your first meeting? My first meeting, yes, sir. Why don't you briefly, do you know everybody sitting at the table?
This is Brian Webb. He is the interim chairman of the Department of Anesthesiology here.
I don't think so.
Sorry, wrong
I
department.
don't think so.
Yeah, he's the interim chairman of the orthopedic department. He also hails from Carmel, Indiana, which is where I happen to hail from. We both went to the same high school about a little over 2 decades apart.
That just demoralized me. I mean,
Well, you got 2 people from Carmel on this committee. You should be enthused about that.
Perhaps someone should notify law enforcement.
Maybe them too.
if everybody would, just briefly give your name to Brian so he knows who you are.
Andrei Oshapinsky, and I'm patient.
Brian, we have 3 community folks on this committee so that we get their input.
Or Norrin.
In front of Trent Petty, sorry.
Yeah,
Today you're Trent
Much
Petty.
easier.
Put your name tag is next to it.
Do you want to be Trent Petty today?
Is Trent Petty?
Yeah, you are Trent Petty.
Maybe Trent lives a pretty good life.
Let's ask Trent if he wants to be one NORAD.
Yeah, let's not bother with that.
30 minutes, I got a feeling.
Yeah.
Okay, then, those are the only two things we have to act upon. The next one is the patient experience from Laura.
Good afternoon, everyone.
Good afternoon.
It's nice to be here. As you all know, I love to speak about this, so thank you for having me back. The front slide that you see up here on the screen actually demonstrates a really important point. And as you heard last month with the perioperative team, when they came in and shared the work that they've been doing, they talked a lot about the quality components of what has happened based on specific tactics that they put into place and some of those safety precautions and avoidance of errors that they've been able to come up with. But there's also been some really great work that's happened on the patient experience side. And so we've utilized the same technique and tactic across the network. And so I've mentioned this to you all before over the course of the last 4, 5, 6 months. But it's really important for you to understand. And so I thought I would go through that today and talk about the work that's being done by this group of people that are here and the importance of that work in order for us to drive overall rating. So when I think about patient experience, I never think about it as a separate bucket, if you will, to quality, because the sweet spot is where the two come together. Our patients tell us what is the most, our patients tell us what's the most important thing for them when it comes to the work that we do by unit, by clinic, by area in the hospital. And typically those things are, did we explain things well? Did we listen to them? Did we manage their medication, talk to them about side effects? They're very clinical and very quality oriented. And so our surveys don't ask questions like, did we smile at them, or were we nice and friendly? That's not what we're measuring any longer. And so in our world, the patient experience world, that we almost never talk about service without the intersection of quality. And so I'll show you a little bit about what we do here in this. This actually was presented at our quality fair that we had within the last couple weeks. And what's interesting is the team pulled this together, and I think they did a really nice job. So I thought it would be worthwhile to share with you. And the work that's happening that was actually talked about during the quality fair is now on the road. So that team is doing a road show around all of our clinics and inpatient units and all to really make sure that this is a very thorough process and one that is stuck. So the problem that we found over the course of the last 9 or 10 months was that we have a lot of data that our leaders look at. We have a lot of data that our frontline people look at, and they were feeling a little bit overloaded. And frankly, we would go to specific areas and they had multiple tactics that they were working on within that department or within that area or within that clinic or unit, and they were feeling a little bit overwhelmed. And so our team decided one of the things that we would do is try to simplify this work so that it was more meaningful, more targeted, more focused, more aligned, and be able to get to the end result that we were looking for. So that was a problem that we came across. What we decided to do was utilize our vendor tool and determine what the priority was for each of these areas, and then develop action steps and items to go through in order to create the best results. What the reports show us is the statistical correlation to moving overall perception of care. We've had a lot of success on that on the inpatient side, as you've seen, with the award that we just were awarded in August. And we've seen a lot of success in the areas where they've really taken this targeted approach. And so we have used this across the network, and it's working, and I'll show you what some of these results look like over time. But we still have a lot of work to do around this. This is not an easy fix. It's not a fast fix, but it's the simplest approach that I know of and that I've used over the years that helps us move the needle as fast as possible. So we utilize the Plan, Do, Study, Act formula, that template Lean Six Sigma type process that we use. And we developed our plan, which was to identify that question. The next thing was that we actually collaborate with each individual unit, with each individual clinic, or with each individual area in order to build action steps that are very simple, that are very targeted, that are very focused, and that are aligned across our network. And then we take 90 days at minimum to study that work. If there is no movement within that period, or we have not changed our work processes or habits, we then continue that work until it is hardwired. And we've seen that a couple of times over the course of the last 9 months or so. Many times that 90-day period is a long enough time frame to hardwire the work so that if we change focus, we don't lose the effort and the intent of what's happened over the last 90 days. And then the last step that we do is we make any necessary changes that we need to with the priority question. So over time, what we had done was teach our leaders how to pull the data, but we found there was still a lot of confusion around there. So for us, as far as a cycle of improvement, we are now actually pushing those reports out to them and working with them on a monthly basis to make sure that their action plans are solid, that if they need help, that they are ready to do that. The results that we've seen so far, in Rate the Hospital, we've seen a 3.4% increase in the 90 days that we had pre-focus and then after focus. So within a 90-day period, we saw a 3.4% increase. That's about average per year nationally. So we're seeing already an average result in 3 months that you would normally see in 12 months. So it's a really great, quick hit approach, but it's also very simple for the team. The other part that's really interesting that you see in the other graph that's on here, we look a lot at how many people love us and how many people like us. And what that means in our world is what's the percentage of patients that rated us a top box answer, meaning a 9 or a 10 on a 10-point scale, or they said, yes, it always happened, or yes, it definitely happened. Those are our top box answers. So we get the percentages for those. We had a 6.5% increase in those that love us in that 90-day, in that period from prior year to today. That's huge. That's over double what we would see on average. So we're getting some really good results from this. Again, we're not where we need to be, so we're going to continue this process, this very targeted and aligned approach. But I did want to at least expand on it a little bit for you and answer questions if you had those on what our approach is and how we are getting to the place where we sustain our vast improvements that we've made over the long haul. So I talked about the fact that we're now pushing reports and building those action plans in a better way than we have before. We've done a lot of back to basics training. We are scheduling more of those, so we're going back over some of the tactics that have been taught over the course of the years that are scheduled now between now and the spring of next year. And then we also share best practices among each other so that we are not reinventing wheels. So we've created a leader toolkit by priority question. So if you have the same priority question as another leader, you have what's now we consider a JPS certified tool, so that it's standardized approach across the network that you would see as far as the tools and tactics that are proven to work here at JPS. I'm going to pause there for a minute and see if there are questions or comments that you have based on this approach.
Could you give me an example
Sure.
when you say that tool?
Sure. So what we do, so for example, let's say that one of our questions is that we're not explaining things as well as we could. We have found here at JPS that if we do a couple of things within that framework, we get better results. One example might be there is a keywords reminder template that we would put on every clinic door, for example. So when you walked in that door, you would say, remember to explain things to patients in a way they could understand. That's a very simple tool. We also created rounding questions that are targeted around that priority question. So as the leader goes in and rounds on staff, for example, they would say, talk to me about how you are explaining things to patients in a way they could understand, and harvesting some of those best practices and doing recognition around those. Another thing that we might do, that we have done, is create rounding questions for the patient. So when we're in with the patient, we say, tell us, when we explain things to you in a way we understand, what does that mean to you? How do we do that? What types of things are you seeing? Based on those results, we then have different tools that and education that we provide to the leadership team so they can spread that to their staff.
Thank you.
You're welcome. And we've never had, just to add on that, we've never had a place where we actually captured that. So we have that now. So it's almost like a library that as a leader you can go to and say, gosh, here's my priority question. Let me pull these tools and tactics so I don't have to reinvent them.
Well, I was very glad to hear the question of how you interact. I'm sorry, go ahead.
There is a relatively tangible discussion of problems, such as grievances, complaints, and all
Right.
that often point to opportunities for improvement. Relatively specific things, many of them of pretty common occurrence. What I was wondering about is, where do you have room for that? Because it
Yeah.
all sounds very, very abstract, all about leaders and charts and almost algorithms. These are real people with real lives,
Yeah.
real stories, and they have real problems.
Yep.
And so the numbers can kind of give top management some level of feeling. But when it comes to a real focus on opportunities for specific improvements, you need some kind of descriptions, stories, whatever. Tell me how that goes in.
Yeah, so just to expand on that, the percentage of complaints and grievances that we receive is relatively small compared to the number of unique visits that we have here. And when I say that, it's over 1 million unique visits, 1.5 or something, and we had 500. I mean, it's very, very small. However, there's some really good nuggets that are in there that we actually do a lot of education around and training, and we trend that data. So what we find with it, and you could speak to this because you're in those meetings, but a lot of the complaints and grievances that we find come from lack or gap of communication. And whether it is they didn't understand, we said it 4 times, but they still didn't understand it. It's kind of like you can't just talk louder and they get it. You have to say it in a different way. And so we do a lot of education around those things. We actually tell some of those stories when we are going in to do education. So we'll say, here's why we're here, because we had a patient who was very concerned about the fact that they couldn't understand the way that the medication connected to their plan of care. So tactically, what that would look like on the inpatient side is we would do a better job with bedside shift report. We would train on bedside shift report to be able to connect those dots and use the care boards in those manners. So tactically, we take the story, we tie the story to a tactic, and then we actually monitor to make sure that that tactic's being done.
So one of the things that I see as a pattern is that people who are working in, let's say, emergency room environment, exposed to a lot of stress.
Yes.
No matter what the general instructions are, doing the same training, they know the rules. They just at times are unable to follow them. Now, what can be done about it? Sometimes little, and sometimes they are things that could organizationally help, let them take 5 minutes break, prayer or meditation, whatever they like. This type of learning from the experience that we see in problem situations, how is that coming into the process here?
So we actually have restructured. I think I'm going to answer this. If I don't, please ask again. Okay. We've actually restructured a position within the patient relations team to be able to trend our data better and pull those stories out so that we can compare it with the patient experience data that we get from NRC and from our vendor. And with that, with the combination of those, we will be able to do a better job of doing what you're asking about. A lot of times, and it's interesting because I've spent a lot of time in the ED with the physicians down there. I've spent a lot of time with the team members, with the leaders down there. And they do an amazing job, frankly. And our results in the ED today are better than they have been in a year.
Right. My
When
last
it comes to
comment on
patient
this is that
experience.
This is not about the numbers, because, you know, the number of complaints in every business is 10 to 1. Problems in relation to complaints, you know, we have a very high level of complaints from the employees, because they know how to complain. They know they are entitled to complain. A lot of other people don't. So I'm not discussing the issue of how many problems we have. My focus is totally opportunities for improvement. So if you have 10 complaints or 1,000 complaints, you can learn things from this. So it's not like I'm trying to say we have a lot of problems. I'm just saying we have a lot of opportunities for improvement. And I'm not sure that anything I heard so far is kind of focusing on that in this, which doesn't mean this is not useful. It just means that it doesn't seem to address some of the things that I call, you know, learning from experience of patients.
Yeah, we do. We actually do take all of that grievance and complaint information and we tie it into this. It's just tied through statistical analysis with what we're working on. But we absolutely take every single one of those that we hear and we either teach on it, train on it, observe it, any part of the learning process that we can from those nuggets that we hear from patients. They're very, very valuable. We do the same thing with our comments on this data. So we combine those together so that we're able to take everything and say, what's the highest priority? And then we work from the highest priority down the line. But it's all very, very important.
Well, I think it was taken care of. Of course, now I was going to ask it, it's there.
Yeah.
Okay.
We have lots of data and lots of comments and lots of information that come together. So we action on every bit of it, and this is what you're starting to see happen. So.
To that, to your point, let me give you some tangibles though, because you have a balance between numbers and statistical information and what individuals are saying. We had heard for a while that doesn't show up statistically about what we had on our televisions in the room. And there was a concern that people said, I want something that is soft music. I want some type of non-denominational information that I can watch, that I can see. We heard a lot of those concerns and complaints about what people were watching in their rooms. And we tried to accommodate that from the music side to the non-denominational side to a multiple of other things that people could watch. And so that's very tangible of the experience of somebody who's laying in a bed for 4 and 5 days, or even a day or a day and a half to get their mind off of their situation. The only thing we couldn't accommodate is ESPN, because they were a little more challenging financially for us. No disrespect to ESPN, but we try to do that, and we try to do that with our food too. And we're trying to figure out how you develop a menu that people can stay within parameters and order a few different things. So we do try really hard to take the statistical information and put it on a human level and listen to what people say, as well as the employees as well. And that it's a little bit easier with employees because they're here every day. We see what their needs are as well.
Yeah. And I think what I hear you saying is, you know, numbers don't move move healthcare workers, right? And so it's the stories that do.
My point is really that in the example of interactions at the grievance committee, there's a bunch of people who are actually working on the floor. They are kind of making decisions. They are actual leaders. They are making decisions. They learn from each other. When we pick up an issue here and someone says, oh, we did that as a solution, it doesn't matter if it shows up in complaints 100 times or just 5. In some cases, it doesn't show much, but it's a relatively low-hanging fruit that is relatively significant to much larger number of people than it's what shows in the statistics. And it can make a lot of difference. And that kind of learning from actually paying attention to individual stories. And of course, I'm totally for, let's not go into some kind of, you know, very rare issues. You know, we have to focus on things that have potential to make difference. But I'm just saying that statistics does not always reflect the real opportunities for improvement, or the easiest, the most significant opportunities for improvement. That's my point.
Yeah,
Good
it's
point.
a good one.
Great point.
Okay.
Laura? Thank you
Thank you very much.
very much for being here. Next, we have Mona. I'm gonna have to cut you off at about 15 minutes after the, can you make it?
Yes, sir.
Okay.
Good afternoon, honorable members of the board. My name's Mona. I'm the Executive Director of Quality. I will only take 5 minutes of your time. And my goal today is to be able to present to you a report of our quality outcomes. We will be focusing on our infection control status, and I thank you in advance for your kind attention. So one of the things that I want to mention before I go to the slide is the results that you will see. To me, having been exposed in different organizations is really amazing. And it is a result of the teamwork and collaboration that has occurred here at JPS. And I feel so fortunate to be part of what we are doing here at JPS. So, Dr. Rosinia has been talking about Destination Zero, eliminating patient harm. And if we look at this slide on our catheter-associated urinary tract infections, we as a hospital have shown that we can reach zero. If you will compare the previous fiscal year, we had 36 catheter-associated urinary tract infections. And as we close the fiscal year, we only have 11. So that is 36 compared to 11 today. Central line-associated bloodstream infection, or CLABSI. The previous fiscal year, we had 13, and today we have 17. However, if you will look at the trend line, we can see that we have 5 months without any events, catheter-associated CLABSI infections.
Can I ask a quick question?
Yes, sir.
Sometimes the number doesn't tell us the severity of the patient, or their result in
DT,
mortality.
pull your microphone a little closer.
In mortality rate and all that stuff. So sometimes bringing the number down doesn't mean the other side. So is there any way that we can track for those also as well?
Sorry, sir?
You know, sometimes the number, as you reduce the case, but we don't see the severity of the case.
Yes. So that's a great question, sir. Actually, we have what we call a Zero CLABSI task force. It is an interdisciplinary team that is led by our director for critical care services, Debbie Zafer, and she works hand in hand with infection control, our staff nurses, and also our Black Belt Performance Excellence team. And so we have also our physicians. I forgot to mention, we do have our physicians in the task force. And what happens is when there is an outlier every month, infection control starts a mini RCA. It's a root cause analysis where an in-depth analysis of each case is done. And so every case is analyzed, and we look at what went well, what we could have done better, and how can we make sure that it doesn't happen to the next patient. So to answer your question, we do have an in-depth analysis.
And if that means later on we'll be educated on that as you have more collected, more.
Yes, sir.
You know, what we're trying to get to is at the end of the day, what's the cost of care down the road, right? Because you have maybe like one case, but it can equate to 36 cases.
Yes. So just to answer your question on the cost of care, our critical care division has actually done something that is, again, to my mind, is phenomenal, because we have gone for actually 24 months without a Zero CLABSI in our P5 department. And when we talk about cost of care, that would be the area where we will have the greatest cost of care.
Thank you.
So we look at our surgical site infections, SSI. For colon procedures, we're actually, again, doing very well. Compared to 25 the previous fiscal year, we currently have 10. So when we talk about patients coming out of surgeries at JPS, we can say that we have better outcomes compared to other organizations. And then surgical site infections, hysterectomy procedures. This, again, is a great story because fiscal year, the previous fiscal year, we had 15 cases. And for this fiscal year, we have 3. And then for hip and knee procedures, Dr. Webb must be very proud because last year we had 9, and this year we have 2. Is that my time, sir?
5 minutes.
Okay. Sorry. So our last slide, I wanted to just put in perspective what are the improvement work? What is the improvement work that the JPS team has put forward? And those were the 0, those were the decrease that we have seen compared to the previous fiscal year. And today, when we look at our Leapfrog Hospital Safety Score, we started with a score of 2.459 in the fall of 2015. And today, we have a score of 2.8312. And when we talk about improvement, to me, that is improvement. And specifically, we made a significant improvement in HCAPS with our nurse communication, our CLOBC, COTI, SSI, our methicillin-resistant Staphylococcus aureus, MRSA, and our C. diff infection. And I know that when you look at the Leapfrog website, JPS is still listed as a C, but to me, that is a high C. C+. And I know that the work that we are doing is making an impact. And with this quarterly data, if we continue our focus and our awareness and our collaboration, I know that we will get to where we would want to be as an organization. And I know it's not all about the award, it's not all about the public recognition, but it's also to tell the public that at JPS, we do provide quality patient safety care.
Go ahead, please.
Could I just ask on some of your procedures, like the hysterectomy procedures, when we're looking at previous fiscal year and this year, numbers and procedures stayed close to the same, or did they go up or down?
Great question. Spoken like a black belt. Ms. Du Bois, actually, our procedural cases actually does not have a lot of impact on the numbers because we look at all our cases. So, yes.
I do understand that. Yes. I was just asking on hysterectomy procedures, if your surgery cases went up, it doesn't mean that hysterectomy cases went up. And I was just asking him, when I'm looking at this, I am to assume that on the procedures, they are comparable to last year, or we didn't have a big drop, or you didn't have any, and the reason I have 0. That's all I was asking.
Yes, that's a great point. I think it has stayed the same.
Okay, all right.
DT, you had a...
I was just curious, at these numbers, is it inside the hospital, or does it include post-acute also as well?
It's inpatient, sir.
Inpatient only?
Anybody else have? Brian, for the 2 infections for the orthopedics, those are hip and knee replacements.
The difficulty with the orthopedic procedures, Mr. Chairman, is that we track those for 90 days post the procedure.
Right.
Yes.
Are you tracking post-acute care at this point?
Tracking what?
Post-acute care.
Post-acute care, we track it.
The reason I'm saying that it doesn't have anything to do with us today, but as the successful of the bundle payment and CJR and all that stuff, as they start expanding, we may get caught in the next few years without understanding the total cost. Just want to make sure it doesn't affect us at all now, but in the next few years, it can really, really throw us in into a planning session that we don't have time to plan down properly.
That's a great point, sir, and I'll make sure that I relay it to our community health leaders, and we'll make sure that we work with case management also to make sure that we have better care coordination.
Because for the, you can pull some data from Medicare now so that you can start analyzing, so that you can start matching to see what if we into that program, if we stay on track 1, track 2, or track 3, how is that going to affect our payment rate and stuff. It just preliminary, but it exists out there if you want to go down that path.
Thank you, DJ.
Okay, anybody else, questions, comments? Very good.
Thank you, sir.
Just for everybody's, the new leapfrog stuff that just came out yesterday, if you go to their website, you can see the things that we do very, very well, and things that we get low scores. And Frank and I were talking about this earlier today, was we have a lot of stuff that's presented to us about where we do really well. And where I'd like to start some of the conversations is where we don't do very well. But a lot of stuff's going on behind the scenes too.
Yeah. Yeah.
Okay,
Right,
that's it. So we will
go to close.
go to closed session. According to the Texas Chapter 551 Texas Government Code, blah, blah. If we could come back in just a couple minutes.
Surgeries.
Oh, this was just for me.
Don't ask me what you want to say. Don't ask me that damn question.
You guys ready?
I told you what's out there.
Okay.